Thank you. I'm glad to see you here, and I hope the talk will be somehow useful to you. And first, before I start, I would like to know how to make this talk more relevant to you. So may I ask you a question? Who of you are medical doctors, clinicians? All right. Researchers, epidemiologists? Okay, great, great. Any other practitioners like psychologists, social workers? Oh, great. Okay, welcome. All right. So I see that we have a number of researchers and some medical doctors. We'll try and adjust the focus. So in this talk, I really hope that it will be kind of interactive. I don't really want to lecture from the tribune, and if you have questions, please, you're more than welcome to ask and interrupt me, and if you want to clarify something or you have a question, just right in the middle of the talk. And so we'll go over, the talk is devoted to HIV-related stigma in healthcare settings. And first, what we do, we will bring a little update on what HIV/AIDS is. I'm sure you're very familiar with what it is, but just quickly to be on the same page. Then we talk about epidemic and global perspective, and we'll focus particularly in Russia because the study was done in Russia. And then we will talk about I think that's going to be kind of core of the talk, is what stigma is, what discrimination is, what HIV-related stigma and discriminations are. And we're going to bring an example of study that was, as Robert said, my master thesis project. And I'm going to present the results of the study in the style of a manuscript. So we go over, this will be our background section. We'll go over study methods and objectives. And then we will see the results and discussion. Will this do? Okay.
No, change your talk completely now.
Oh, is it? Okay, so a few abbreviations which I'm going to use throughout the talk. I'm sure you're familiar with them. First, CSW, commercial sex worker, intravenous drug user or intravenous drug use, IDU, men who have sex with men, MSM, and HIV plus will mean HIV positiveness, that individual is HIV positive. Quick update. I'm sure you know that HIV is human immunodeficiency virus, is a causative agent of AIDS. The virus multiplies in particular cell line within the body and causing syndrome, which is called AIDS. And before mid-90s, HIV infection and AIDS was nearly 100% lethal. But things changed in 1995, late 1995, early 96, when the antiretroviral therapy became available, so-called highly active antiretroviral therapy. And with it, which halts replication of the virus, technically, having the therapy, nowadays we should have any single case of AIDS. But I'm sure you know that we do have still cases of AIDS, and we have AIDS-related mortality. And partially, it's explained by the topic of our talk, by the HIV/AIDS-related stigma. More of the background. Here are 3 routes of transmission of HIV: bloodborne, sexual, and from mother to child. For bloodborne, it's intravenous drug use, either blood transfusion or professional contact. We're going to focus a bit more on professional contact. Here are the numbers of which can give you an idea about the risk. So here's the question: what is more infectious, HIV or Hep B, hepatitis B, viral hepatitis B? Hepatitis B, yes. So if we take the typical professional risk, percutaneous needle stick exposure, so if we have a syringe needle and prick the skin, the risk of acquiring HIV, given that there is HIV in the needle, is 0.3%, means 1 out of 300 cases. You prick 300 individuals and only 1 will be infected. With Hep B, do you know what the number will look like? Robert knows. Anyone else?
It's about 20%.
Yes, 20 to 30%, meaning 1 in 5, 1 in 3. So it's considerably more than that. But what is perceived as more dangerous, as more infectious? Often HIV is perceived as more infectious. And why is that? There is no simple answer why is that. But one of the answers is that HIV, especially in the beginning and even nowadays in certain countries and certain settings, is lethal. We have 33 million people who are HIV positive on Earth, and so far we have 25 million individuals who died due to AIDS. Because of such immense epidemic, this epidemic produced a serious global response, and I think it's a good trend that the number of AIDS-related deaths declining, though it should be 0, but at least it's, even if it's not 0, it is declining everywhere in the world, besides, you can guess where. Yes, besides Eastern Europe and Russia particularly. And in the world, number of new cases, new HIV cases, is declining everywhere in the world, besides, you know where. That's a map. I'm sure many of you have seen that. So this is prevalence of HIV, and Russia has intermediate prevalence, which is estimated to be somewhere between 0.5 and 1%. Here's a slide to illustrate that trends in Russia are not so good. These are number of people who died with died from AIDS, AIDS-related deaths, number of AIDS-related deaths. And you see that the only region where we have really prominent trend to increase in this number is Eastern Europe. And to give you idea that, like, geographically, Russia and Ukraine make 90% of the Eastern Europe. And in regards of the HIV-related statistics, Russia and Ukraine also make 90% of all the statistics. So that means these figures are basically Russia and Ukraine. HIV epidemic in Russia is not well controlled. We have a few records. One of them is largest regional increase in number of people living with HIV/AIDS, and we hold this record for several years in a row. Another particular feature of HIV/AIDS epidemic in Russia is that it was related to intravenous drug use. So here's the question: what was the engine? What route of transmission was driving epidemic in the U.S., especially in the beginning? What route was the most common, popular in the U.S.? Men who have sex with men, homosexual transmission. What route is the most common in Africa? Heterosexual, yes. Eastern Europe, we have our own way. It's intravenous drug use. So the epidemic from the very beginning has specific features. But now we have a process which is called generalization, and I'm sure those who are epidemiologists know that this means that epidemic from the core group, which in the US was men who have sex with men, in Russia it's a group of population of IDUs, it expands to the general population. That's called generalization. And this process usually leads to really a big increase in number of cases unless prevention measures are taken. So that's an update on HIV infection in Russia. Do you have any questions in that regard? Because now we're going to move to the stigma part. Just another thing. Well, this is a map of Russia and the prevalence of HIV. Do you see kind of trend by diagonal going from here up to the north? So knowing political situation in Eurasia and knowing that HIV epidemic was driven primarily via IDU, why do you think we have this trend? What's that? Puppies?
The drug route?
Drug, yes, exactly. That's drug trafficking route. From Afghanistan somewhere here in below, that's how the drugs transported. So, now stigma and discrimination. So, stigma and discrimination. What is stigma? I mean, not what is written on the slide, but what is stigma for you? Yeah, here is the definition of HIV-related stigma. But stigma can be related to anything, to race, ethnicity, sexual orientation, age. What is stigma?
Sort of labeling social terms of negative meaning.
Perfect. Stigma, translated from Greek, means label. So stigma means labeling. Labeling a group, labeling part of the group with certain mark, meaning separating individuals from the group. That's what stigma is. And HIV-related stigma is, by WHO definition, is devaluation of people either living with HIV or somehow associated with HIV/AIDS. And what is discrimination in general? Yeah, please.
Oh no, I was just saying it's part of our sad history.
Well, it happens everywhere.
Everywhere.
Yeah, it happens everywhere. What is discrimination? Yes, please.
Or treatment or behavior towards people with the mark?
Exactly. So discrimination is the result of stigma. First, by stigma, we somehow separate a group into, I don't know, larger, usually smaller part. We separate, and then if we act towards these members somehow differently, this is going to be discrimination. And I've heard like words like sad, poor treatment. Discrimination not necessarily means sad and poor. Discrimination by itself is a sort of neutral term, but historically it got a negative kind of coloring to it. Discrimination can be sometimes can be good, and we're gonna go over it. Why and when it is good. So I think that's it for this slide. But if we go by traditional way of perceiving stigma and discrimination as negative, and usually stigma and discrimination are negative phenomena. In HIV medicine or healthcare or HIV related, I don't know, world, consequences of stigma are usually bad. First, it's lower quality of care. Stigma and discrimination can result in lower quality of care and even up to refusal. So there are many cases that I witnessed that people were refused to be given medical care. Second, this is easy to understand. Lower quality, refusal, easy. Okay. We treat this, we don't treat this. Drug users or someone else go out. Reduced accessibility of care. Why do you think it is? And as a result, lower treatment adherence. Reluctance to participate in treatment and prevention program. Why do you think it is consequence of stigma? Why do you think stigma, discrimination results in lower treatment adherence.
It's like aversive conditioning. If you've gone to a clinic and received poor treatment or felt insulted, you're not likely to go back again.
Exactly. If you go to a place where the services are provided with lower quality, or you were treated somehow under the standard, and yes, you will not go there again. That's very simple. Very simple also, and very important distinction. It's not about actual quality of care. It's all about the perceived quality of care. How do I feel in this clinic? That's very important distinction. Not exactly, they are interrelated, but they're not the same. So my willingness to come back to the place, I don't know, any place, shop, clinic, I don't know, hairdresser, whatever, depends on my feelings, not which are not necessarily exactly the way the clinic is set. And as a consequence, stigma and discrimination promotes the spread of the epidemic. And that's why knowing and dealing with stigma and discrimination, trying to diminish, to decrease it, is very important. We move on. Are you okay? All right. All right. So do we agree that stigma, HIV-related stigma, is bad? Okay. Hopefully we agree on that. But why it does exist? Why it does exist? We know that it is bad. In general, people are, trying to behave nicely, trying to be nice, and why we still discriminate against people living with HIV?
Association. I think with HIV associated with those
Yes.
groups which are not also kind of
Exactly. Exactly. HIV inherits the stigma of the stigmatized groups, like drug users, like men who have sex with men, and so on. Commercial sex workers. So groups that are generally stigmatized. And it happened that these groups were related to HIV. And that's why. That's one of the reasons. But that's, I would say that's kind of historical reason. But there is another reason for why stigma exists.
Well, let me challenge you on that.
All right.
Instead of just thinking that it's entirely historical, like with racism or xenophobia, it may not happen at a cognitive level.
Yes.
But it may happen at a subconscious level where somebody really does have good intentions, but they're not acting in this
Perfect.
way. Or it may happen at a systemic level.
Perfect.
Where there's a minority population, the facilities aren't as good as another location, and it takes time to improve those things. So it can happen at a lot of levels. Yes,
it's definitely a multi-level issue, and one of the levels which I'm actually going to talk a bit more on is categorization, the phenomenon which is called categorization. And this is a kind of stigma generating property of our brain. Our brain is made, yes, and you can see the references here, and if you want, you can read more about that. This property of our brain was proved in a number of studies. So our brain tends to categorize things. Why? Why we do categorize? Why? It's like natural phenomenon. We categorize.
Simplifies decision-making.
Exactly. It simplifies. It speeds up the process. It makes our life easier. We categorize. It's easy when we have black and white. It's easy when we have tall and short. It's easy when we have rich and poor. Okay? You're rich, you're poor. Done. Move on. So that's natural property of our brain. That's all right, but it has to be kept in mind when we approach a patient, where we approach a client when we do a study, that it's a natural property of our brain. Our brain really easily slips to that way. So we have to control it. Without the controlling the going to categorization, we can really easily slip to stigmatizing people. So that's, if you want a take-home message, I would suggest taking this, so that our brain has natural property to categorize, and because of the categorization can result in stigma. And there are many ways to deal with it. And what will be the easiest? I would say that if we try not to assume too much and just try and ask people, if we talk to people, they can tell us very interesting things, which will not actually follow our patterns that we have for them in our brain. Okay. Okay. Yeah, I can talk more about that because I really like this topic, but we should move on. If you're interested, we can discuss it later after the presentation. Well, there is another argument why HIV-related stigma exists, because healthcare workers actually may be at greater risk than general population. But it's sort of controversial. Actually, through use of universal precautions, the risk of acquiring HIV in healthcare settings may be brought nearly to zero. And what else helps us here? What else helps really avoid getting infected in healthcare settings, besides universal precautions?
Knowing the HIV status of some of the patients.
All right. But sometimes we don't know. Besides that, without knowing status, first, universal precautions. That's why they are universal. We use them regardless of the status. That's a really nice way to stop discrimination. We always use gloves. We use gloves with any single patient without taking HIV test first. And what will be the second? Yes?
I guess understanding modes of transmission correctly.
That's fine. Yes, that's one of the approaches. And it's okay.
Access to post-exposure prophylaxis.
Perfect. That's what I was hoping to hear, that there is a post-exposure prophylaxis. So if you take medications for a month after a contact, after risky contact, regardless which kind of contact is it, professional or sexual or drug use, whatever, you take medications for a month, and then there is nearly zero risk that you have HIV. So, yes, and here are the strategies how HIV-related stigma can be reduced. These are mostly for public health professionals. And yes, as you have said, that knowledge of HIV transmission and knowledge of what HIV is can be a key to design a program. Knowledge what stigma is, why stigma is harmful, and how to realize that you're stigmatizing is very important. And the third is about moral. Moral is linking people with HIV to immoral behavior. That's another topic which I can go on for a good week. There is a yes. There is a process which is called moral disengagement. And if we, anyone heard of moral disengagement? Yes. Okay, I see a couple of hands. Good. Moral disengagement is the process which allows us, naturally good individuals, act sometimes really not so good. And it stands on categorization when we categorize on us and not us and them. So it's ingrained in our brain to act nicely towards us. And it's okay, it's also ingrained in our brain, it's okay to not work nicely towards them, not to act nicely towards them. So that's the third thing. And I mean, it's really fascinating. So there, in our brain, there are mechanisms that allow for really something which is maybe seen as really improper or bad things. And there are many examples in the history, as you may know. But we should go closer to the topic of the study, which is stigma expressed by medical students. Stigma by medical students, surely they have, they share the beliefs of the general population of a country, city, wherever they come from. And they further transfer these attitudes into their practices. But at the same time, medical school presents an opportunity to teach doctors how to work in non-stigmatizing, non-discriminating way. And there are studies saying that students are actually willing to learn more. Students don't want to be discriminated. But there are also negative findings. Sometimes schooling can increase stigma. And there are studies, again, one study was done in New York City, showing that schooling, a medical school, can actually increase stigma. Sad, but true. Okay, and why do you think is that? Why do you think studying at medical school can increase stigma? Any ideas? Social status is increasing, yes. What's that?
Confirmation bias?
Confirmation bias?
It's a term in psychology used that people who receive new information, they process it in order to confirm their prior...
Okay. So, yes, so kind of they have something prior to entering the medical school and they tweak the knowledge they acquire just to prove their beliefs. All right, any other ideas? There is another way, which actually is described here in this paper, reference number 5 on this slide. Any other ideas?
They're undergoing an apprenticeship. They're taught by faculty who come with their own.
Perfectly. That's the topic of that paper, that professors actually teach students to be stigmatizing. Professors themselves being stigmatizing have their students learning that. All right. So stigma expressed by medical students is a well-known phenomenon. It varies from country to country and exists everywhere, starting with developed countries, US, UK. There were studies confirming existence of stigma. There were no studies in Russia devoted to that, but knowing the high level of stigmatization of HIV-positive people in Russia, one can expect that students will also be quite stigmatizing. Do you have any questions on general stigma part? Because now we're going to move to the results of the study. All right. Not too tired? Okay. Study objectives. So there were 3 objectives of the study. First, we wanted to assess prevalence of biased attitudes, which is another way to say stigmatizing attitudes, among medical students towards HIV-positive and marginalized patients. Second, we wanted to evaluate distribution of these attitudes among different student subgroups. And we picked gender and year of study. We wanted to compare level of stigmatization expressed by medical students throughout the different subcategories of patients. And we'll discuss more. the categories. The survey was done in Kazan State Medical University, which is medical school in Kazan, Russia. Kazan is a city of 1.2 million population, so it's relatively, it's not too small. We have a medical school there. Then main study tool was 5-point Likert type scale, and you will see in the next slide, you will see how the actual scale looked like. And we had 9 vignettes, 9 examples of the patients. HIV negative, medical doctor, which was always a comparison. Commercial sex worker, negative, IDU, negative, and MSM. And they are HIV positive counterparts. So HIV positive medical doctor, and so on. And we added HIV positive due to blood transfusion to have kind of innocently acquired HIV. So now for epidemiologists, study outcome. Study outcome was measured, meaning the level of stigmatizing attitudes, was measured by the Likert type scale. And we considered as a reluctance to provide medical care these 2 answers: would not volunteer or would very strongly choose not to volunteer. Having neutral and positive answers as non-stigmatizing approach. Okay? I can give more details on that if you want, but we can do that in the discussion. Exposures. Study exposure was, we had a number of exposures. Year of study. Here again, we used categorization. This is a good way to use categorization. Again, to simplify not just thinking, but the process of exploring things, the study. When we categorize, we make things easier. And again, to epidemiologists, why we divide it into clinical and preclinical. What usually is the kind of ground for categorization? Is it our own data or is it something else? Okay, we used logical categorization. So up to the year 3, students don't see patients. And starting from year 4, students start seeing patients. That's why we categorize on that. Okay? Second exposure was students' gender. And then additional exposures / potential confounders concern about HIV, about acquiring HIV in healthcare settings. Any questions about exposure and outcome? Okay. So statistical analysis was pretty simple. After initial cleaning and assessment, we did bivariate and stratified analysis. And then we run log binomial regression. And to say it's, to put it straightforward, these results are agreed with each other to the very great extent. So in the presentation, we're going to talk mostly about stratified analysis, and we have just one slide on the regression, because they're basically the same. I mean, they bring the same results. All right. Here are the results. So out of 436 surveys, what we had, 70% of our students in our sample were female. What do you think about this number? Is it the same as in the US? Do you think the sample was biased? Do you think we were recruiting mostly female students? What do you think?
The majority of female of physicians in many countries in the Philippines form since I think before the war.
Yes, that's absolutely correct. That's the general distribution of the gender in medical schools in the former Soviet Union. Majority of medical doctors in Russia and former Soviet Union countries are women.
It's a slim majority here now for medical students.
Okay. Okay. In regards of the year of study, we have, I mean, it's nearly half and half. So 55% were in clinical years, 45% in preclinical. Mean age was 20.4. That's the categorization results. We don't stop on that because we're going to move to the results of the study themselves. The way I would like to present the results maybe are not very commonly used, so that's why I would like to spend a few minutes on the way the results are presented. Okay, so this is a cobweb diagram, and we have 4 axes here, and axes represent patients. So here, commercial sex worker, medical doctor, drug user, men who have sex with men. And on the axis, you see the level of reluctance to provide medical care. So here, for instance, for medical doctor, we have just a few % of people who said that they will not volunteer to take care of the medical doctor. Okay? The percentage of those who will not volunteer to treat commercial sex worker, you see, was much greater, about 60%. Do you see the idea? Okay. Here we have student category. Okay, and we categorize students as clinical and preclinical, and male and female. And again, to wake up epidemiologists, my question is, why we had to present results in 4 strata? What do we have here? Why don't we lump them all together?
Because they're different.
Yes, and how is it called in epidemiology terms? Interaction or effect modification. Perfect. In our data, we had effect modifications. That's why we had to present them in 4 separate strata. What's that? Okay.
The classic example is to look at low birth weight as an outcome.
Mm-hmm.
And if you look at 100 mothers lumped in with 100 fathers, and you look at the exposures, it's not going to tell you anything. You want to look at the 100.
Yes, exactly.
Because the effect may exist with the mothers, but not the fathers.
Yes, 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 exactly. So we had different effects. We had different results among those 4 subgroups: clinical, preclinical, male, female students. So we will have 4 subgroups. And to add to that, we have here in the darker color, in darker figure, we have results for HIV negative patients. And in the lighter color, the larger figure, we have numbers for HIV positive patients. Okay? So what will that mean? Student who is in clinical years and female, they will be that much reluctant to treat the doctor if the doctor was HIV positive. So this is addition due to HIV positivity of a patient. Okay? The same for commercial sex worker, drug user, and men who have sex with men. All right, here are the results. Reluctance to treat HIV negative physician was, as we may expect, was quite low, just a few percent. You see in every graph. So we have preclinical female, preclinical male, and so on. The reluctance to treat physicians was low. But if we move to marginalized patients, you see that reluctance was much higher. Reluctance to treat was much more prevalent. Okay, also kind of what we could expect. unwillingness to treat HIV positive patients everywhere was larger than unwillingness to treat HIV negative patients. Again, something that we would expect. But again, look at the numbers. The unwillingness can go up to 72%. So 72% of certain patients potentially can be refused to have care, to be provided with care. Any questions on that? This is kind of what was expected, and that's what we've seen. But we now move to something interesting. In general, unwillingness to treat HIV positive or marginalized patients was more prevalent among clinical students. So the more you study, the less nice to your marginalized patients you become. That's what we found. These are particularly prominent differences. For example, for HIV positive drug user, unwillingness to treat jumps from 26 to 54% from preclinical to clinical years. The same for female students. Again, we see that unwillingness to treat jumps when you move to clinical years. Another finding. Female students were found to be more stigmatizing. These are differences. Not everywhere, though. Not to every category. Female students tend to be nicer to men who have sex with men. And male students tend to be nicer, guess to whom? To sex workers. Well, that's what it is. The same findings in clinical years. Any questions on that before we move to regression? Regression? Okay, regression is here. So this was the model building. And the only variable that we excluded from the model because it was insignificant, it was actually concern about acquiring HIV in healthcare settings. We excluded it from the final model. And the regression results actually really represent the same idea as the stratified analysis. So we don't really go deep into that. The same, so clinical students are more stigmatizing, and so things are the same. Limitations. As every study has its limitations, our study also did. The first limitation is related to the outcome definition. Outcome in this study should be really seen as stigma in broader meaning. Not just straightforward intent to discriminate, but stigma in general sense. What we were talking about at the beginning of the lecture, that stigma is different behavior. It may be expressed in different behavior, the different way we look at that patient, different way we act. So we also did not go deeper into the reasons for reluctance to provide care. Maybe we will do in the follow-up studies. Our study was done using convenience sampling. And self-selection bias may be present. But we had response rate around 70%. And since we had both prevalence estimate and prevalence ratio estimate, and they are quite close to each other, we may conclude that if self-selection bias was present, it was not very prominent. Convenience sampling has another consequence, that the probabilistic meanings of the p-value and confidence interval is compromised. But still, confidence intervals and p-values provide insight into the precision. They don't have exactly probabilistic meaning, but they give you an idea how precise or imprecise the results were. Third limitation is that results in our study come from just one medical school, and generalizability may be restricted. But knowing the prevalence of HIV stigma in the society, and knowing that it is prevalent everywhere, we can say that results might be the same in other schools in Russia also. Any questions on that? All right. We're going to move to discussion.
Do the students basically come from Kazan? Is it local or?
Mostly local students. Mostly local students. Though there are some from other cities, yes?
During the clinical training, do students in this university have experience working with people living with HIV, or are they doing?
Yes, they do. Yes, they do. I mean, they work with all patients who come to the clinic, and among those patients, there are HIV positive. Okay, discussion. So, high prevalence of stigmatizing attitudes towards HIV positive patients is not something unique to Russia. For example, in the US, in New York City, and a similar study was done. I mean, there were a number of studies done in the US, but the particularly prominent number was obtained in New York City in early 90s. That up to 80% of medical students were expressing stigmatizing attitudes. So it's not unique to Russia. And knowing the general attitude in the society, in Russian society, towards HIV positive people, our findings are not surprising. But if you ask me why it is so prevalent, we tried and hypothesized why. And here we have 4 hypothetical reasons for that. And I cannot say which is most important and which is less, but I'm just going to present them to you and we can discuss. So first, there may be imperfect infection control in healthcare settings. At least it may be perceived as imperfect. Second, low income among medical establishment. That's a problem. Doctors in Russia are not rich. Doctors are, yes, Robert can give you some insights and ideas how does it look like in the real life. And informal payments do exist in Russia. So, and patients who belong to marginalized groups, they're less likely to bring you something. And maybe that's why they are discriminated against. Marginalized patients may be seen as more difficult, which often is true. Like drug users, they tend to have more comorbidities than people who do not use drugs. And that's the most sad, but probably is true, that socially it is okay to discriminate. Studying in medical school should not increase stigmatizing attitudes, but our study shows that it does. I would say that the question should be really explored. Why is that so? And we should work probably with professors and teachers in medical school. So, and that's my personal pet peeve. Medical school curricula, they usually focus on clinical sites. In medical school, at least in Russia, we do not really spend time on how to talk to patient, how to see patient, how to approach them. We study endless. I mean, I was teaching in medical school in Kazan for 7 years, and we give students an endless list of opportunistic infections, endless list of antiretroviral medications, but we hardly spend a few minutes talking how to approach a patient. So definitely curriculum has to be changed. Any questions on the discussion part? We are nearly at the end. So, conclusion. Majority of medical students in Russia may have negative attitudes towards HIV-positive patients. Most likely they do have them. Reluctance to treat appears to be more prevalent in students of clinical years of study. Reluctance to treat appears to me to be more prevalent among female students. And these findings suggest that more attention to the issue is needed, more exploration is needed, and I think changes are necessary.